won't be highlight of what's the latest. However, we will focus today on how I treat. So without overdue, I would like also to show our sponsors. Can we have the sponsors slide, please? So these are our sponsors. Thank you, Takedia, for being a main sponsor for this webinar series. And we have other sponsors, Gilead, QI, Kirin, and AbbVie, and Novartis as bronze sponsors. Can we have back the slides of the today's session? So it's a pleasure again to meet again and reconnect with Professor Ayalo Teferi. Dr. Teferi is well known to our hematology community, well-known professor of medicine, consultant hematologist from Mayo Clinic, Rochester, Minnesota. Teferi has been well known as an excellent speaker with focus on myeloproliferative disorders. Today we will focus on primary myelofibrosis. So Teferi, you will have 25 minutes up to 30 minutes talk, and then we will have question and answers. So our attendees, please post your questions and answers in the Q&A corner, and we'll explore them and browse them at the end of the talk. Teferi, please, you can go ahead.
Thank you very much, Ahmed. Let me see if I can get the slides. Okay, here we go.
Great.
First, let me start by thanking the organizers for inviting me to this important function. It's my best wishes for everyone to remain vigilant on their health, especially during these challenging times. If anything came good out of this, is our acute realization that video conferencing is a very practical and potentially easier way of education communication, probably is here to stay even after the COVID pandemic. For the next 25 minutes to 30 minutes, I will give you an overview. My topic is how I treat primary myelofibrosis. And the learning objectives would be first to discuss the latest version of the risk model that combines cytogenetic, mutation, and clinical information, so-called MIPS version 2. And then using that, how I approach my patients in terms of treatment strategies. Let me start with giving you a bird's eye view of our extensive experience at the Mayo Clinic. Over 20 years median follow-up, over 3,000 patients with myeloproliferative neoplasms were seen and followed for a median of 20 years. And we published this information last year. And as you can see, primary myelofibrosis is clearly the worst among the three, with median survivals of only 4.4 years, whereas in ET and PV, the median survivals are well over 15 years. And as expected, this is because more patients with myelofibrosis die of leukemic transformation. As you can see here, the rate of leukemic transformation is much higher in myelofibrosis. And interestingly, the rate of thrombosis appears to be the lowest in myelofibrosis as compared to polycythemia vera and essential thrombocythemia. Now, even though I gave you that 4.4 years all comers, most of those patients were above age 60 and mostly above age 70. And therefore, that estimate of life expectancy does not necessarily hold for younger patients. So we looked at the different age groups. And as you can see, in patients below age 40, the median survival for myelofibrosis is actually 20 years, not 4.4 years, and obviously much higher, in excess of 35 years for PV and ET. But once you get on to the middle age group of 41 to 60, then the median goes down to 8 years, and above age 60, the median goes to 3 years, mostly a function of age. Now, shortened survival is not the only bad thing that can happen with myelofibrosis. The other major thing is quality of life compromise. And the four major things that compromise quality of life include anemia. A lot of people are transfusion dependent. Massive splenomegaly with all its attendant complications. Constitutional symptoms, including severe night sweats and fatigue. And cachexia. These patients lose lean body weight. And these are the issues that these patients have to go through. Now, so when you have a patient with myelofibrosis, you know that they have shortened survival. You know that their quality of life is going to be a challenge. So the question is, what can you do for them? Here I have listed the current therapeutic options in myelofibrosis. And it is very important that you pay attention to this slide. The only treatment that is curative or has the potential to improve survival is allogeneic hematopoietic cell transplantation, period. No other treatment has been shown to improve survival in this disease. Now, if the patient cannot have that or is a poor candidate otherwise, then we go to palliative treatment, which include observation alone. Many of my patients are just on a watch and wait procedure at this point. Treatment of anemia, that includes thalidomide and prednisone, which is my favorite, but then androgens, danazole, lenalidomide, pomalidomide can also be used. Treatment for symptomatic splenomegaly, usually I start with hydroxyurea, and if they fail, I go to JAK inhibitors. But ultimately, they may have to have splenectomy, even after that. And we have done a lot of splenectomies after failure with JAK inhibitors, and some patients do reasonably well. Constitutional symptoms can only be addressed with JAK inhibitors. So if that is a major problem, then we don't really have an option. Some patients may have extramedullary hematopoiesis in any part of the body, including the long bones with severe bone pain. Involved field radiotherapy with very small doses can address that effectively. And then, of course, there's always experimental therapy. Now, as you could see, the treatment options go from observation alone all the way to allogeneic stem cell transplantation. So the question is, how do you choose the patient for what treatment? Obviously, you don't want to put some patient on allogeneic transplant if their expected life expectancy exceeds 20 years, for example. On the other hand, it doesn't make sense to wait and treat with drugs somebody whose life expectancy is less than 5 years. So the question is, how can we risk stratify these patients very effectively? And fortunately, we have now developed, along with our Italian colleagues, the Mutation Enhanced International Prognostic Scoring System. We have updated it with the version 2.0. So we call it MIPS v2. And the three major components of this are cytogenetics, mutations, and clinical features. Now, the clinical features that are included in this model are primarily anemia, presence or absence of circulating blasts, and presence or absence of constitutional symptoms. Each one of these is weighed on depending on how adverse the feature is. For example, if you have a very high-risk karyotype or even an unfavorable karyotype, you cannot be very low risk or low risk. You are almost already in the intermediate risk patients. On the other hand, if you just have a moderate anemia or just circulating blast without much else, you can still be in the low risk group. In order to be in very low risk group, you should not have any adverse features, which means this only applies to CALR type 1 mutated myelofibrosis. Because as you can see, if you don't have the type 1 CALR mutation, you're already at a disadvantage for 2 points, which means you can't be very low risk and probably also not low risk. Now, if you're wondering about what very high risk and unfavorable karyotypes are, this is a nice slide that shows you the very high risk, which are usually true for any myeloid neoplasms: monosomy 7, isochromosome 17, inversion 3, 12p minus, 11q minus, and interestingly, trisomies 21 and 19 are also very high risk cytogenetic abnormalities. The good risk are, of course, normal, loss of Y, chromosome 1 duplications, and the more frequent ones, which is a 20q minus and 30q minus, are also good risk. And of course, trisomy 9 is also good risk. Now, if you can then score these patients, then there is an online scoring system, depending on those three components, and you can come up with very low risk, very high risk categories. And whether you use all patients, regardless of age, or you use the patient population which is transplant age, that is age 70 years or younger, the slopes are very similar and tell you that very low risk patients have an almost normal life expectancy. Excellent 10-year survival of 86%. The low risk are not too bad, with a 10-year survival of over 50%. And remember, these are the patients with 1 or 2 adverse points. Then things get a little more worse as you can go to intermediate. And then, of course, with high and very high risk, and as you can see here, anything above 5 points puts you into high or very high risk. And there, the 10-year survival is clearly less than 10%. 5-year survival is usually less than 10%. And these are the patients where you really have not much to lose by being very aggressive and going for transplant right away. Now, so this is how we risk stratify patients. And once we risk stratify using MIPS v2, then it becomes easier as to how we're going to approach the treatment for this patient. Obviously, if the patient is very low risk or low risk, I think treatment does more harm than good. So my recommendation for very low risk or low risk is really just observation, unless they are treatment requiring because of a big spleen, anemia, or what have you. So in general, observation only. Now, if you have high risk or very high risk, I don't think it makes sense to waste the time by trying this and trying that. I think we should aggressively pursue allogeneic stem cell transplantation. Obviously, if the patient is not transplant eligible, then at that point, I would seriously consider novel agent clinical trial. These patients have very short survival, and it doesn't make sense to try JAK inhibitor or this or that. If your plan is to prolong life, then you should try some novel agents. If it is palliative, then of course you can use those. But then there is an intermediate risk group where they are treatment requiring, but not as bad. So their survival, 10-year survival is almost 30%. Now, these are the patients where you could give palliative treatment, and the type of palliative treatment depends on what the problem is. If the problem is, for example, anemia, you don't want to give JAK inhibitor. You want to treat with an anti-anemia drugs, such as androgen preparations, danazol, thalidomide, and prednisone. If the problem is primarily splenomegaly, I usually like to use hydroxyurea first before I exhaust all my options. And if they fail, then I go to ruxolitinib. And there are a lot of patients who fail ruxolitinib and ultimately need to be splenectomized. And then if the problem is primarily constitutional symptoms, only ruxolitinib can effectively address this issue. If the problem is localized bone pain or symptoms from extramedullary hematopoiesis, then involved field radiotherapy would be the way to go. Now, where is the evidence that supports this approach? High risk, very high risk transplant, not so high, not so low, or low or intermediate one, try conservative treatment before transplant. So this is a big study. It was published in 2015 from our European colleagues. Clearly shows that if you did transplant in low risk and intermediate one risk patients, you stand to lose more patients. In other words, you could compromise survival. This patient would have done better without transplant, as you can see here. But if for patients who are intermediate to or high risk, clearly the patients who are transplanted appear to survive better than those patients who have not been transplanted. So this is primarily the evidence that we use in order to advocate for transplant. Now, is there anything else that can improve survival? Not even close. This is, for example, 100-patient study from the Mayo Clinic, where we treated this with one of the JAK inhibitors, momelotinib, and we compared this 100 treated patients with 442 not receiving the treatment, but adjusted for DIPS plus risk score. So we're talking about high, intermediate to risk that receive momelotinib or not. And as you can see, there's absolutely no difference in survival. We've shown the same thing with ruxolitinib. And even the company-sponsored analyzed data does not show a significant difference in those patients randomized to ruxolitinib versus best available therapy. So those are the evidence that we use to really strongly recommend transplant if you have high risk or intermediate to risk patients. Now, very important to know is that these patients who are getting treated with JAK inhibitors, for example, momelotinib, their survival is not impacted favorably by that treatment. Their survival, at the end of the day, all depends on their molecular signature. So if they are high risk molecular signature, such as ASXL1 ASRF2 mutation, they're going to do very bad, regardless of whether or not they got the JAK inhibitor. The question is, Can transplant overcome the adverse effect of mutations and cytogenetic abnormalities? And this is a Mayo Clinic experience. 56 transplanted patients over many years, allogeneic transplant, compared with strictly controlled, matched for age, DIPS, karyotype, and clearly, the patients who have been transplanted have benefited from the transplant. But more importantly, in this study, we were able to show that transplant overcame the adverse features of karyotype or even DIPS appropriately. In another study from the City of Hope, they again show that transplant was not affected by the presence of HMR mutations. And again, they showed a very high risk might not do as well, but still there is a plateau. There is hope for salvage with transplant, even in very high risk cytogenetic groups. So I think I have convinced you for very high risk and high risk patients, transplant is a better option. The question is, what do you do if the patient is not transplant eligible, or if the patient does not have a high risk disease, but a lower risk, but which is treatment requiring? There, it depends on what the problem is. If the problem is anemia, then you want to use anemia drugs such as androgen preparations, danazol, thalidomide, and prednisone, not ruxolitinib. That would only make the anemia worse. If the problem is splenomegaly, I usually like to start first with hydroxyurea, and then if that doesn't work, then I go to ruxolitinib. Because you have to remember, the effect of ruxolitinib is finite. It usually goes away after a year. So you don't want to exhaust it. Maybe you should save it for a rainy day. And then obviously splenectomy is there. Constitutional symptoms, again, only ruxolitinib can help, and localized bone pain, radiation only. Now, in terms of the JAK inhibitors that are available, we now have two that are FDA approved, ruxolitinib and fedratinib. And then there are two that are waiting for FDA approval, momelotinib and pacritinib. They all work very similarly in terms of their effect on the spleen or their effect on symptoms. Very similar. The difference, there are two differences. One is the effect on anemia. Most of them make the anemia worse, except momelotinib, which appears to make the anemia better. So if it was available, you would say, why would I use the others if momelotinib can improve the anemia? Well, the problem is sometimes about 20% of patients, momelotinib, can get a thalidomide-like sensory neuropathy. So you have to take that into consideration. And obviously, because of the side effect profile, we choose ruxolitinib over fedratinib as first-line treatment. Now, a lot of you are using ruxolitinib. I think it would be nice to have some practice points on it. It's indicated if you have a big spleen or severe constitutional symptoms. And remember, even though this drug can cause anemia and thrombocytopenia, sometimes you have no other option. Sometimes you have to use it regardless. The short-term side effects, as I say, was anemia and thrombocytopenia. Long-term side effects that are worrisome, immunosuppression, opportunistic infections, but more importantly, protracted myelosuppression. If you're thinking for your patients some sort of a new novel therapy in the future, then that patient might become protocol ineligible because of the protracted myelosuppression for ruxolitinib. And special concerns, of course, you can't just stop the drug. You have to beware. You have to taper it down. So it is very important to remember that. So what's the role of fedratinib? To be honest with you, in our practice, we really am not using it that much because the time the patient fails ruxolitinib, unless the patient is intolerant, then it is, of course, you can use it. But if the patient fails, either refractory or relapsed, then the patient is in a very bad shape. Cytopenias, very difficult to use that. And even then, it doesn't work very well. There is a paper published, I think it's in AJH, and that a third of patients, maybe 25% of patients, might get some benefit after failing ruxolitinib. It's worth doing, but in my experience, it's very difficult to treat this patient. I would prefer participation in a clinical trial rather than using yet another JAK inhibitor. So what's new? Well, not much, unfortunately. There's this luspatercept, as you know, which is a trap which traps the TGF-beta superfamily ligands so that they cannot engage the receptor in order to stimulate SMAD signaling. SMAD signaling appears to be contributing to ineffective erythropoiesis. So by blocking that, then you allow late-stage hematopoiesis go on. So at least that's the supposition. And obviously, luspatercept has been shown to have an effect in beta thalassemia, which is where ineffective erythropoiesis is the prominent feature. And there is a New England Journal of Medicine paper that says that it might work in low-risk MDS with ring sideroblasts. The problem is, in my practice, we don't have that many patients with ring sideroblasts. This is a very expensive drug. And then there is a 14% maintained response at 1 year. So I'm not very excited about this option, but it is approved if you want to try it for MDS with ring sideroblasts. Now, would it help you in myelofibrosis? Well, if it doesn't help that as much where there is infective erythropoiesis, then it's not surprising that it didn't work very well in myelofibrosis. This is a very expensive drug, and by itself, there was absolutely no effect on the anemia. Very small. And it appears that in patients that were taking ruxolitinib, maybe there was some effect. Now, that has to be controlled appropriately, and we just have to wait for additional information. I'm not very encouraged so far about the role of luspatercept in myelofibrosis. Well, there are a lot of other treatments that have been presented, that are being done. To be honest with you, I am not enthusiastic about any one of them. There's a lot of studies, for example, adding drugs to ruxolitinib, or using other epigenetic-based therapies like bomedemstat, BET inhibitors. Very underwhelming, not impressive at all. And then there are even other drugs, targeted therapy against CD123, so-called SLO4, navitoclax, which is like venetoclax with ruxolitinib, and metformin. All of these are being tried, but I have not been impressed by any one of them. So I would like to complete by reminding all of us about some unresolved issues. I think everybody agrees that transplant is a very good procedure to pursue in high-risk, very high-risk patients. And the question is, can you use ruxolitinib before, during, or after transplant? That is being tested and being studied. At this point, I don't think any strong recommendation can be made one way or the other. What do you do with a big spleen before transplant? You just leave it alone, let the conditioning regimen take care of it, Or should you take it out? Should you radiate it? Should you do ruxolitinib? There are no very clear answers. Most of the studies done here, the results are not conclusive and they're not controlled. My own take is if the spleen is less than 10 centimeters, leave it alone. Just do your transplant. If the spleen is bigger than that, then I think it's reasonable to consider ruxolitinib or splenic irradiation. The good thing about splenic irradiation is you don't have to taper. You do it once, and then you just go ahead and with the condition. With the ruxolitinib, you have to make sure you taper it down before transplant, and then you know how patients react when you taper down ruxolitinib. So splenic irradiation and ruxolitinib appear to be the two options for such patients. With this, I'd like to complete my talk, and I'm happy to answer questions. Thank you.
Great. Thank you, Professor Teferi. Excellent talk as usual. Concise overview of primary myelofibrosis and the management. I think we have a number of questions that we wanted to again explore. Let's have that slide of the sponsors. Yes, and I would like to thank our sponsors before we proceed to our Q&A. Takeda as a main sponsor, and we have other pharma industry that in the future, as I said in the beginning, we will have part of the session that's sponsored by pharma industry, highlighting latest in the development and hematology. All right, let me see how we get to the questions here. Yeah, this is a question that's related to children. So, Ayalo, can we apply the same treatment strategy for children?
It's a very good question. As you know, I am an adult hematologist.
Right.
And I don't want to confabulate. I don't want to say things that I don't have major experience with. I do not see why not, as long as we understand the pharmacokinetics and everything, which is age dependent. I do not see why we can't use it for children. I will be a little more conservative when it comes to children. So I would observe the most important thing with children is to make sure that we're not dealing with a congenital, a hereditary issue with thrombocytosis or with myelofibrosis or autoimmune myelofibrosis. The differential diagnosis is broader and has to be addressed more seriously in children. But otherwise, I really don't see why we can't use some of these treatment strategies for children as well.
Right. All right. Another question here is MEPS dynamic score?
Yeah, absolutely, and that's why we, if you remember, DIPS was also a dynamic score. So from then on, we really just stayed on the dynamic score. The dynamic score basically means that you can apply it at any time. You don't have to apply it from the time of diagnosis. So you see the patient, you can just apply the score right then and there. So yes, it is a dynamic score.
Okay. Yeah, another question about erythropoietin or erythropoietin-stimulating agents for anemia and myelofibrosis. So do you have experience? What's your experience?
Yes.
From Nadim?
I have lots of experience because I'm older. I have been using this for many, many years. And here are the things. First of all, I have not been very impressed by its effect, number one. Number two, patients' splenomegaly gets worse. Whenever I put them on erythropoiesis-stimulating agents, their spleen gets larger. And especially if they don't have a palpable spleen, then you might actually cause another issue by starting erythropoiesis-stimulating agent. The other issue is that it usually does not work if you are transfusion dependent. So even if it's going to work, it has to be in patients that are anemic but not yet transfusion dependent. And obviously, we check the usual things that we check for MDS, like erythropoiesis level of usually less than 200. But in general, I have not been very impressed with ESS, and I usually don't use them. I usually just go to thalidomide and prednisone.
Right. I think we get the same experience as well. Another question from Dr. Beiruti is TB reactivation in peritoneum a contraindication of JAK2 inhibitor in a patient with myelofibrosis and ASXL mutation awaiting transplant?
Obviously, this is a very difficult question to answer. Dr. Alberuti clearly knows that the use of Jakavi increases the reactivation rates, opportunistic infections, CMV, and all sorts of things. The same issues that you worry about when you give it to transplant patients. But at the same time, sometimes you have to take some risks. If the patient is dying otherwise and is in dire need of palliative therapy, then you might have to use it, bite the bullet, and maybe just start the isoniazid along with it. So I wouldn't say it's an absolute contraindication. If you have something alternative to use, then use the alternative one. But if not, then take the necessary precautions, do the prophylactic medications for the infection, same with CMV, and then you can use the Jakavi.
Yeah, makes sense. The other question here, how practical is the new prognostic system? Molecular test availability in the non-academic centers. Yeah, from Dr. Salim Shammer.
Yeah, very important question. Very important question. Now, remember, we still have some prognostic scores that do not rely on any molecular data. The International Prognostic Scoring System, the Dynamic International Prognostic Scoring System, IPS and DIPS do not require any cytogenetic or molecular data. So if you don't have that, you can still use those. But in order to use the mutation enhanced and the other ones, then you need the complete information. Obviously, here in the United States, we like to use the MIPS V2 because we have the means to get all the information we need. But in underdeveloped countries around the world, it's very difficult to get those. So you could just continue to use DIPS in that instance.
Yeah. All right, this is a practical question. So for one of our non-transplant patients with a huge spleen, we did splenectomy, and a few weeks later, the liver doubled. So how often do you see that?
Very often.
Yeah.
Almost universal. After splenectomy, you have to hit the patient, either with a JAK inhibitor, hydroxyurea, to keep the liver at bay. The liver size has to be kept under control. So yes, that's one of the reasons why we don't do splenectomies as much. So if you decide to do splenectomy, then you have to continue treating the patient with adequate doses of hydroxyurea or some sort of JAK inhibitor.
I think for that reason, we prepare, to try first radiotherapy to radiate, portion of the spleen. What's your experience with that?
Our experience has not been very good with radiotherapy outside of the transplant situation we talked about. The reason being, number one, if you see an effect, it only lasts for 3 months at most. And then the spleen size comes back with a vengeance. But more importantly, and this is very important, patients get protracted cytopenias, and the platelets go to zero. You pour in the platelets day in, day out, they don't budge. So you really put the patients into severe protracted pancytopenia. So we usually don't like to do radiation, but in general, it's best to just go ahead and do what you need to do before the radiation.
All right. Next question is, what's the role of T cell replete haplo allo in very high risk myelofibrosis?
Obviously, there are many variants of allogeneic transplant and transplant in general. There is unrelated, there is haplo, there is a repeat haplo, all sorts of things. There is not enough data, and clearly there is no controlled study to tell us how these things compare to the garden variety way of doing transplant. Every center is doing their own protocol. There are centers which do T-cell replete, there are centers which do high-dose cytoxin conditioning, and everybody is coming up with some preliminary information that needs to be ultimately tested in a very larger group of patients in a controlled fashion. So at this point, I do not recommend that over unrelated. I would probably use unrelated before I use T-replete up. But maybe I don't know enough yet. Maybe the information is not there yet. We just have to wait. But for right now, I choose unrelated over all the other variants.
Right. One question here is clarification on the size of the spleen. When you said 10 centimeter, do you mean below costal margin, or is that the total by ultrasound?
Very good. That is below, palpable, below the left costal margin. Not ultrasound is palpable below the left costal margin. And you know, that can be 15 centimeters too. It's okay. In other words, we don't have, 10 is not a magic number here. The question is it manageable? 10 to 15 centimeters, then they can proceed with transplant, in my opinion. But if it is like 20 centimeters and it's really big and I'm worried about graft rejection or delayed graftment or what have you, then I might want to do something. Like maybe give some ruxolitinib for the patient or some splenic irradiation. But it has to be done under protocol.
Right. So regarding the dose of ruxolitinib, this is related to thrombocytopenia, but in general, what do you aim? Do you aim for the 20 BID, or what's your, and how often do you reach it?
That's a very good question, because what you hear about written up or what have you is not what is practical. If the patient looks good, and cytopenias are not an issue, you can go with 20 BID as a starting dose. If the patient has platelet counts that are kind of iffy, below 100 and what have you, then there's nothing wrong with starting 10 milligrams twice a day and then slowly bringing it up. But here's the situation. What if the patient has severe splenic symptoms, constitutional symptoms, but the platelets are, let's say, 30,000? What do you do then? I personally think that it is a waste of time trying to give 5 milligrams every day, 5 milligrams twice a day. No, that's not going to work. If what you were trying to do is provide relief for that patient, then you have to hit it hard, at least 10 twice a day, and then deal with the complications. Give platelet transfusions if you have to, and hope that time with time, because I have seen some patients, actually, the platelets start getting better. Even though the platelets started at 25,000, when I started at 10 milligrams twice a day, they start to get better, and then you can even increase it. So it really depends on what it is that you're trying to achieve, and is the risk justified? So you have to use the art of medicine here. There is no cookbook approach here. You have to say, okay, what am I trying to do? Is that risk justified in this particular patient, and so forth. It's not like we have too many other options. So we have to do what we have to.
Right. All right. And I think our last, or the one before last question: will you take patients with intermediate 2 or high risk myelofibrosis with a child A class liver cirrhosis?
See, these are questions, these are protocol driven. The decision really depends on the transplant protocol. Transplant center, which is doing the transplant, they are the ones who decide whether they want to transplant this patient or not me. Not me. I would, if the patient doesn't have any other option, I would recommend transplant. But I am not the transplanter. I used to be a transplanter. I did transplant for 16 years, but I have not done it now for the last 16 years. So I can't decide. So you have to talk to the transplant center and see what their policy is. It depends on the policy of the transplant center.
Right. Now, generally speaking, I think I will ask this question, which sum up at least 2 or 3 questions. So now, myelofibrosis is a disease of elderly, and again, transplant, yes, is the curative modality. However, it's always difficult to take these patients to transplant. So the majority will end up with, the conservative, non-curative, I would say, intent treatment, trying to lessen their symptoms, improve their quality of life, etc. So what's your comment on this? For those patients, especially, what's your experience? We might in our region, we might have even less portion of patients that will end up with, going with transplant.
Ahmed, I have nothing to add to your excellent articulation of the issue. Really, you said it all. Not in many words, or few words, but you said it all. It's very difficult, and it's like I said, you do what you can do. If you cannot do transplant, then you work with what else you have. And it really doesn't require an expert to tell you what to do, because you already know. You see the patient, you treat the patient, and you have availability of a certain group of drugs, and you use this and you use that. It's voodoo medicine, as you know. You try something, and if it works, then you continue, and if it doesn't, then you try something else. And it's very difficult. But there is no expert opinion. There is no a stepwise approach. You have to take into consideration what are the available options. And for this particular patient, everything has to be individualized. For this particular patient, which option would be most appropriate? And that's what you do, and that's what most doctors do. And really, it's just use your judgment.
Great. I think with that, we'll conclude our session. Professor Teveri, thank you again very much for such elegant talk and discussing the questions. Thank you for our audience and attendees for these excellent questions and for, again, staying with us until the end. This is, again, as I mentioned at the beginning, this will be a weekly exercise. So we look forward to have all our attendees, again, tuned in with us every week. The time might change, so we wanted to give, again, opportunities for others to attend. So not necessarily every Saturday. The next meeting will be Saturday. However, probably the following meetings might change during the days of the week. Again, with that, I would like to thank everybody for being here, and have a nice day, everybody. Thank you, Teveri, again.
Thank you, Ahmed. Take care. Bye-bye.
Bye.